Hi, good evening. I'm Dr. Philip McMillan, and I'm going to be taking you through a recently published Japanese paper looking at vaccine induced heart failure. Now, you may think to yourself, well, this is just one of those cases. But I am here to explain to you why this is technically part of my predicted heart failure epidemic. If you have not seen this video, this was done over 2 years ago, and it was just based on the science around what would be happening with the heart and autoimmunity. The problem we have nowadays is that everything takes time, and people tend to be impatient and they expect things to happen instantaneously. And so when you make a prediction, they think it will happen right now. In reality, when we look at what my focus has been around autoimmunity, we're talking about a 5 to 10 year timeline. The problem is, by the time we recognize this, there is very little that can be done. So, part of my challenge is how to make people aware of that critical term that I keep on mentioning, storm, the spike triggered autoimmune response mechanism. This is likely to affect multiple organs, including the heart. And so, this is why it's so important. And I'll take you through this paper, Japanese study, just to help you to understand a little bit more. Remember, first thing, if you are on YouTube, make sure that you click the subscribe button. If you don't see it, there's usually a bell on the screen here. Click on it and subscribe. That way you'll see the videos come into your feed when I do them live. Additionally, I want to make sure that you join our growing community. And what we are doing is we're building a healthcare revolution. So please join us at the Vision Med newsletter. It is absolutely free. Just put in your email address. And once you have registered with us, we will give you as a reward a free ebook. That ebook is something about nitric oxide, and it's helping people to understand a little bit more about what is going on with the virus. Really important information. It's a free ebook looking at nitric oxide in the sinuses. This is where you protect against COVID. If you can prevent it breaking through this mucosal barrier, you will reduce your risk. This information is free. Please get it, share it with others. That way, we can all learn the value of nitric oxide because it is so easy to fix just through humming. If you want to get the science around it, make sure you get this ebook. So let's get back to this case here. This is an important case, and in truth, when I explain it to you, don't expect that there are going to be any remarkable answers that you can use in your circumstance because this is oftentimes related to older people. And because the system is not cued into it, the diagnosis will often go missed. And it's because the diagnosis is missed why I think the outcomes are going to be so significant in the long term. But there is no easy way for you to raise this awareness with your doctors because they may not be thinking about it. And therefore, it makes it very difficult for you to get in the middle. And additionally, when I look at this case, I'll show you that this timeline is very different to what can happen with many other patients. So let's take a look at this paper here. This is case of biopsy proven inflammatory dilated cardiomyopathy following mRNA 1273. This is a Pfizer third dose immunization. And so this here paper was published in July 2024 in Heart Failure, and they were looking at vaccine associated myocarditis following SARS-CoV-2 immunization. And they're saying it's mainly in young males after the second dose. And this was looking at a case in an older female in terms of making the diagnosis. Before I take you any further in that, I'm just going to quickly remind you about the basics with regards to the heart. And I'll show you a few images here to help you. So this is an image of the heart with the layers of the heart. And you can see here, this represents the heart muscles here, the right and the left ventricles. And the right ventricle pumps blood through the lungs, it comes back, and then the left ventricle pumps blood through the aorta to the rest of the body. The left ventricle tends to have more muscle in it, and this is the what they call the intraventricular septum. 4 chambers, and this heart keeps us alive. If you do a section through the heart, you will then see these different layers, which I'll go into a little bit more detail in another slide. And if you look at the muscle layer in a microscope, this is what it would look like. So here is again a more detailed look, a closer look at this heart. As I said, this here is the left ventricle, the one that pumps the blood around the body. And so if this gets weak or flabby, it can then have an impact on how well the heart is able to function. So when they talk about dilated cardiomyopathy, what they mean is that this heart muscle almost gets flabby. And it's like what would happen with a balloon. You know, if you've blown up a balloon multiple times, the elasticity is gone and it blows out very slowly. That's kind of like what would happen in dilated cardiomyopathy. The muscle wall would get thinner, it would be flabby, it wouldn't contract as well, and that's why the person would go into heart failure. Additionally, you have to remember when we talk about myocarditis to understand the layers of the heart. On the very outside is a thick pericardium. This is like a bag, a leather bag around the heart to protect it. In between the heart and this is a layer of fluid. That's where, if it gets inflamed, it causes pericarditis and pain. That's what we call the pericardial cavity. Then you have the heart muscle, as I had explained to you. And then on the lining on the very inside is a thin layer of endocardium. And this part is what is affected in myocarditis, the muscle itself. And when we look at the muscle fibers, they would tend to look like this. They're very well connected with each other so that the electricity passes through it. And when the electricity is passing through, it makes a contraction. And that's how the heart muscle shortens and contracts and pumps blood. And what you would find in myocarditis is these then get inflamed. This is supposed to represent inflammation. With they then get inflamed, they then get fibrosed, so they don't contract as well. And so instead of muscle, you get almost thick collagen tendon-like material in the heart, so it doesn't contract well. It's difficult for it to work, and that's what would happen in myocarditis. One of the important points is that usually when this happens, it is very difficult to reverse it. And so this is why when we talk about myocarditis and when people ignore myocarditis, I think to myself, you don't understand the long-term implications that come around myocarditis. So let's look in a little bit more detail at this. And this breakdown, just in case you can't see it, because sometimes it is not necessarily available or it is not liked to be done in such great detail, you may have to follow me at Substack. So just look at that link below if you're not able to see this breakdown at this point. So let's go back to the paper here. And what we'll do is we'll take apart the case report. So this is the case report here. It's talking about a 78-year-old lady. So she's not young, but she was generally previously healthy. And her family doctor had admitted her because she had dyspnea or shortness of breath 11 days after receiving her third dose. This is the Pfizer dose. Okay. In her background, she had a history of mild dementia, but no other risk factors for coronary artery disease. So, 4 days after being vaccinated, she started to have palpitations. That's where the heart is racing, and shortness of breath, which gradually worsened. And so this is why now her family doctor on day 11, that's a week after the symptoms have started, have referred her into hospital. She had no recent travel history, no contact with COVID, no infectious prodrome. She didn't drink alcohol. She didn't smoke cigarettes. She wasn't using drugs. And when they saw her, her observations were fine. Temperature was fine, blood pressure was fine. The heart rate, however, was fast. And this is the palpitations that she was feeling. and she was struggling to get oxygen in her lungs. The oxygen saturation is usually above 95%. In her case, it was 90% on room air. And she had jugular vein distension. That means that the pressure in her heart was building up. And so the backup of pressure in her heart would then go to the lungs, which is why her lungs would get soggy like a wet sponge. She couldn't breathe as well. And then the pressure goes to the right side of the heart, where there's problems with the venous supply coming back from the legs. So usually they then have swelling of the legs. That's why they get leg edema. So that's all classical of what we would expect with regards to heart failure. Now, when they looked at the results, and this is now them looking at the results here, and you can see here, and maybe I should make this a little bit bigger. Um, and so you can see here, when they looked at her ECG, it was going fast. She had a right bundle branch clock, wouldn't worry too much about that. But there was a change from her previous ECG performed the day before admission. And so there were changes on her ECG that suggested that something was happening with the heart. Her white cell count seems as though it was normal, and her troponin, which measures the damage to heart muscle, was elevated, 156, where it was normally supposed to be less than 26. And similarly, this test, the brain natriuretic peptide, BNP, was 1300 when it's normally less than 18. So this is a significant elevation and quite suggestive of heart failure. And then when they did her echocardiogram, this is like an ultrasound of the heart, they could see that there was what they call hypokinesis, kinesis meaning contraction. The heart muscle was just not contracting properly. The left ventricle was big and flabby, and she had high pressures going into her lungs. So that's a typical characteristic of what you would expect with regards to heart failure. So it fits. The reason why she would have been referred into hospital and the reason why this would have ended up in a paper was largely because they would have done the association in terms of time. Because it was only 4 days after the vaccine the symptoms started, and by day 11 she was in heart failure. So there was a clear temporal association between the two. But here's the problem: she was almost a little bit unusual. Based on what I observe, many patients don't make the connection at all. They don't even think about that there was a recent vaccination when they start having changes in symptoms. And they are not encouraged to think about it. The system doesn't seem to want them to know. And so instead of us telling people, listen, if you've been vaccinated and you notice any changes, please let us know, because we would want to find out to make sure this couldn't be a vaccine induced problem. Instead, what happens is people get ignored. That's one of the worst things that could come out of the pandemic, and it's going to completely damage trust in the system because so many people didn't even try to make the correlation between the two. Unacceptable. And you need to be looking for it. A lot of people think that when I talk about these issues, I'm looking for problems. Absolutely, yes, I am. That's what you're supposed to do. You don't assume that it's not going to be problematic. No, you look for problems. I'm here to advocate for patients. I'm not trying to get the pharma industry rich. I want to make sure the patients are protected. And so you must observe very carefully those people who don't want to look at this kind of thing. You then have to ask why. Anyway, getting back to the paper, what they found is that they then went on to do an endomyocardial biopsy. That's where they take a sample of the tissue. So they put a catheter in the heart and they take a small piece of the heart muscle and then they study it under the microscope. That is truthfully a gold standard way of diagnosing myocarditis. But it's not without risk, so therefore it would probably not be done unless you really want to find out. And truthfully, it will only happen in very specialist centers where you have significant cardiology input. And so the truth is that it's probably not available to most patients who may have a concern about what may be going on. What they found when they did this is that they found that there were no B lymphocytes or eosinophils detected. That means that it wasn't allergic, and it's interestingly not related to antibodies. So there are no autoantibodies because these B lymphocytes were not detected. However, they found macrophages, CD3 T lymphocytes, meeting the quantitative criteria of myocarditis. So, what this means is that it is a cell mediated immune response. That means that after she had the vaccine, it triggered the immune cells to target the heart muscle. And cell mediated immunity is actually pretty serious stuff. And so it shouldn't be underestimated in terms of the impact that this can have on someone. Now, again, I'm going to tell you another bit of bad news about this. Because when they then got that biopsy, they then realized that this was likely to be autoimmune triggered by the vaccine. Now, they did do an autoimmune screen of the patient, which they didn't find anything. However, because of the temporal relationship between the vaccination and the dilated cardiomyopathy, it led them to make the diagnosis of COVID-19 vaccine autoimmune myocarditis. Now, what it meant is that because they made that diagnosis, they put this patient on steroids, 30 milligrams a day, and they kept her on it, and they followed her up to 6 months afterwards, and they found that she had recovered considerably. So this patient had a relatively good outcome. But this is the problem. Who is going to therefore get an endomyocardial biopsy to know that you've got vaccine induced myocarditis, to then be put on immune suppression to allow the immune system to stop doing ongoing damage to the heart? Very few people will get that. And so here is how it usually presents. Heart failure is rarely sudden. And so you just have to remember that the timeline is easily about 5 years, maybe up to 10 years. Somebody, they get a bit short of breath on exertion, going upstairs. Then you may find a little bit later they start to have some swelling of the legs. It's mild. They then go on diuretics. They have an echocardiogram and they're managed and they plod along for years until they gradually find that the heart muscle starts to fail over time. That's the general trajectory of heart failure. But here is what we're seeing now. And if you actually, this is the bit that I want you to be aware of so that you can push your clinicians to think about this. That's what I'm having to do. I'm educating you how to push people. When you have a history, if somebody had been fine, and this is what it sounds like, because I take a detailed history when I'm talking to these patients, because I really want to see what is the trajectory. And I've heard this story so many times. So, what I ask the patient is, did you have shortness of breath on exertion prior to a specific time period? So I'd say, at Christmas, were you fine? And they'd go, yeah, I was fine, no problem. We're going walking with no issues. And then I'd say, so when did you start having symptoms? And they would usually find that it was a relatively sudden onset where they found that they were just short of breath, no chest pain. Then they had the swelling of the legs, and it just gradually progressed over a month. By the end of a month, they go and see their doctor. Then they come, then you do an echocardiogram, and they're in full blown end stage heart failure with a cardiac, with a an ejection fraction of 30% when it's supposed to be up to 60%. So that's how they'll usually present. The problem with these patients is that they have missed the timeline because they have already had symptoms for, say, a month. it's probably not going to help giving them steroids at that point. And if you don't specifically look for the association in terms of the time frames with regards to a temporal association, if you are not really carefully looking for it, you will not see it. And so this is the reality of where we are. Let's look back at the paper here for a few more points. So this is in the discussion of the paper, and the link is in the description as well. So they're talking about vaccine associated myocarditis, autoimmune myocarditis, has a number of characteristic histological findings. And again, I pause you here. Again, histological findings. What that means is they've got a piece of the tissue involved. They have then put it under a microscope after being stained and sealed in formalin. And they then look at this. So the pathologist or the histopathologist will look at this and make a diagnosis. Histology is the foundation of Western medicine, but it's hard work. And we don't have as many pathologists these days. And so it's not as easy to get. And so what we have seen in the context of the pandemic is a lot of people have been talking about, well, there are no issues. We can't find anything. Well, that's because you haven't been doing histological analysis. You only find serious stuff when you look at histology. I can't even find autopsies. This is why whenever I come across any kind of study that includes histological analysis, absolutely, I go and look in detail, because that's where you find the answers, the true answers as to what exactly is going on. It pointed out here that there was infiltrate of lymphocytes, macrophages, and CD3 T lymphocytes. They had cardiac microthrombi, little clots in the lungs, that was comprised with platelets. So that suggests that there was a vasculitis, inflammation of the blood vessels. And this is what would be contributing to the necrosis, the death of these myocytes in that vicinity. So this is important stuff. And once you have scarring like that, it doesn't recover. And so this is why, again, when people talk casually about myocarditis, even in young people, wow, they just had some myocarditis. Just remember, if there is scarring of the heart, that scarring is permanent. The question is whether or not they have enough cardiac reserve to not have symptoms. And so what you will find, and this is why we're likely, not likely, this is almost inevitable, this heart failure epidemic, as I said, the reason why it's inevitable, it's similar to what happens in sports. So people understand this in football. You have these footballers who are playing high contact sports, they're damaging their knees all the time, and they're still able to play. But they then retire in about their mid 30s, and by the time they're 45, they start having significant arthritis. And that's because there was damage to the cartilage when they were playing sports. Now, it was worth it because they were paid so much, but that damage can't be undone. And what it means is that they will therefore likely get earlier onset arthritic problems. So, in the same way, if you have cases of myocarditis with inflammation, fibrosis, and just imagine that 10% of the heart muscle was taken out. In a young, fit person, they'll be okay. They will not have any symptoms. But when they are about 60 and the heart is under a bit more pressure, or if they had a heart attack or something, suddenly their reserve is not the same as the person who didn't have myocarditis. And that's one of the problems is people keep looking for issues now and they say, well, we haven't seen any issues now, it's no big deal. That's not how medicine works. The damage that is caused now shortens the time frame for disease presentation. That's how it works. Now, that's a challenge because at the moment, nobody seems to be taking this stuff seriously. And so, if they're not taking it seriously, what it means is that the damage is ongoing broadly across the population. Because I'll tell you this, she had no chest pain. And it would have been so easy in someone 78 years old, she's older, she's now got heart failure. Well, that's it. It's okay. It's probably just her heart is failing. You would not be actively looking for myocarditis unless you were very suspicious, especially if you have not looked specifically for the temporal association. And that temporal association is within 28 days of them having had the vaccine. Patients don't even remember. The doctors may not think about it. Nobody notices. How many patients have I seen like that? It's incredible. And this is why this is such a serious issue. I don't have a solution at the moment. And what I'm mentioning to you is important information. But I guess what you can do with the information is that you can be on alert for your family members. Meaning that if they had a relatively rapid deterioration in their heart function that was not directly related to a heart attack, because they would tend to know when they look at the echocardiogram, their ejection fraction is now 35%, they're on diuretics, they had no problems beforehand. You can do the work of looking for the temporal association. And at the moment, people may not take you seriously, but what happens is that if you then mention it to the doctor, that, actually, this happened 3 weeks after she was vaccinated, the doctor will have to then document that or make sure they document it. He may not take it, well, that could be coincidental. But if everyone starts to do that job and everyone starts to look for it, very soon doctors will be hearing it all the time. This person had the vaccine on the 29th of April, and by the middle of May, they were in heart failure. Do you think it could be connected? Initially, people will say, well, there's no evidence. But over time, as you start to build the questions, it is natural for people to start asking, well, could it be? That's all we need. We just need the scientific community to acknowledge the risk first and then try and figure out how we can mitigate this huge epidemic that is sitting upon us. As I said, I predicted this 2 years ago, and it was just about the science, autoimmunity. If you have autoimmunity, you're going to get long-term myocarditis and heart failure. The time frames, however, are not so easy to predict. And the reality is that if we leave these things alone, by the time we recognize it, there is very little that can be done. That would probably be the worst outcome. And so there is still a chance that we can make a difference by raising awareness. And that's where everyone has a part to play. So, again, as I close out, remember, join us on the Power of Vision Med newsletter, and you will get, as a reward for joining our newsletter for free, we will give you a free short ebook explaining about nitric oxide and how this helps protecting you against COVID-19. Nothing is perfect, but every little bit helps. So thank you for this more extended presentation. And if the middle bit is missed out, please make sure you take a look at it on our Substack, where you will get far more information helping you to understand what is going on. Have a great evening.